Hi! Today our group will present about congenital Talipes equino-Varus. Club foot is a congenital deformity of the foot and ankle characterized by equinus deformity at the ankle, inversion at subtalar, adduction at the midtarsal joint, cavus and internal tibial torsion. Talipes equino-Varus can be defined as tali means ankle, pes means foot, equinus means foot pointing down like a horse's foot, and varus means deviated towards midline. Midfoot cavus, forefoot adductus, heel or hindfoot varus, and hindfoot equinus are the main deformities in clubfoot. Fixation of the clubfoot described when the foot is inclined inwards, axially rotated outwards and pointing downwards. The calcaneus, navicular and cuboid bones are medially rotated in relation to talus, and are held in adduction and inversion by ligaments and tendons. Cavus develops when the front of the foot overpronates and compared to the back. When a characteristic appears along with other symptoms as a part of a hereditary condition, it is referred to as syndromic, while idiopathic is when it occurs alone.
The reported incidence of CTV ranged from 0.39 to 7.0 per 1,000 live births. The incidence of congenital talipes in Malaysian neonates was reported to be 1.69 per 1,000 live births and 1.26 per 1,000 live births. In 1988, a study was carried out in the maternity hospital in Clayel and there were 8,369 live births in the hospital with 49 neonates were found to have congenital talipes. The incidence of CTV was 4.5 per 1,000 live births while that of CTCV was 1.3 per 1,000 live births. The male-to-female ratio of the neonates was 1:1 for CDV and 3:8 for CDCV. From the tables, it shows that congenital talipes was significantly more common in the low birth weight neonates of less than 2,500 grams, which is p equal to less than 0.001, and the Chinese had a higher incidence of CDV than the other two races, Malays and Indians. It can be concluded that the incidence of CTV and CTCV in Malaysian neonates was much higher than Caucasians and Polynesians, and the incidence of talipes in Chinese neonates born in the hospital was high, when bilateral CTV was found more common in Malaysian neonates. Males were noted to be affected 2 to 4 times more often with CTV than females by other studies, while both sexes were equally affected in the Malaysian neonates. Lastly, it is suggested that the most likely cause of congenital talipes in Malaysian neonates is due mainly to multifactorial genetic background. Etiology of the condition. The cause of CTV is not yet known, but it is not caused by embryonic malformation as the development of CDV occurs in the second trimester of pregnancy. However, several hypotheses have been proposed regarding the underlying factors that drive CDV development, which are joint bone hypotheses, positional hypothesis, neurological hypothesis, vascular hypothesis, connective tissue hypothesis, and developmental arrest hypothesis.
Next, we move to clinical features. Clubfoot can be unilateral or bilateral. It affects both males and females. In the ratio of approximately 2:1, the calcaneum is rotated inwards under the talus, giving varus of the heel and the entire foot. The foot is unable to reach dorsiflexion greater than 90 degrees. Club feet are usually shorter and wider than normal feet and may have creases at the midfoot and ankle. Clubfoot results in atrophy of the calf. The ankle and hindfoot is in equinus like plantarflexion and varus, and the Achilles tendon is contracted. Lastly, leg length disparity is regularly seen. Pathophysiology of clubfoot is unproved, however. Genetic component is strongly suggested. Unaffected parents with affected child have 2.5%-6.5% chance of having another child with a clubfoot. It's also linked to PIDX1, where the transcription factor critical for limb development and common genetic pathway may exist with congenital vertical talus, which is a rare congenital condition caused by neuromuscular or chromosomal abnormalities in neonates that typically presents with a rigid flat foot deformity. Other studies also have mentioned that arthrogryposis, dystrophic dysplasia, myelodysplasia, tibial hemimelia, and amniotic band syndrome may be the causes of clubfoot, and various hypotheses, including the talus cartilaginous anlage defect, abnormal tendon insertions, neurogenic reasons, and retraction fibrosis in fetus.
Management of CTV was divided into two, which are assessment and treatment. Assessment of CTV consists of screening, active and passive range of motion, classification and scoring, while treatment of CTV consists of conservative and surgical treatment. There are two methods under conservative treatment, which are Ponseti and Kite's method. For conservative Ponseti method, it consists of several serial plaster castings ending with tenotomy of the Achilles tendon, Treatment by Ponseti method must begin in the first days after birth, as plaster casts are changed every 5 to 7 days. There are 4 steps of Ponseti method, which are: firstly, hypersupination of the forefoot for cavus correction; secondly, constantly abduct the forefoot with cutter pressure; thirdly, ankyliotomy to correct the heel equinus; and lastly, splint of Dennis Brownfur for long-term maintenance of the abduction of the feet. Next, for conservative Kites method, it differed postulate in congenital clubfoot treatment as follows. Firstly, the adduction is corrected by abduction of the foot with an anchor point in the medial plantar compartment. Next, the varus is corrected by aversion of the posterior plantar department. And lastly, the equinus of the medial and anterior plantar departments are corrected by progressive dorsiflexion. However, Kites method possess many inaccuracies, and inaccurate formulations lead to slow and disappointing results, and most cases resorted to surgical management. And professionals who have used both methods preferred Ponseti method, as it found that Ponseti method demonstrates higher results in the correction, achieved in a shorter time. For the surgical treatment, it's actually and options reserved for correction of any remaining deformity. Minor joint sparing surgical procedures, for examples, those that do not involve the ankle or foot joints, are thought to result in good long-term outcomes with pain-free feet. Examples include: first, Achilles tenotomy, surgical release of the Achilles tendon, which have been shown in very young children to result in direct elongation of the tendon. Second, tibialis anterior tendon transfer, which aims to restore the balance of musculature around the foot by making the tibialis anterior muscle pull the foot directly up rather than up and twisting in. And third, in severe cases, relapsed CTV may require a combination of these procedures or major bone or joint surgery to correct the position of the foot and ankle. For the prognosis, it is difficult to compare one foot deformity with another, as there is no accurate standard of guideline. However, it is generally agreed that the primary treatment is conservative and that it should begin at birth with the care of professionals. Stretching and strapping with early elongation of the tendocalcaneus when necessary has proved to be the most successful method of treatment. Recourse to further operative treatment is necessary if the results become progressively less satisfactory as the skeleton of the foot becomes more mature. Some of poor prognosis factors in CTEV are late presenters with neglect in the treatment, hereditary disorders, severity of deformity, associated cavus, clawing of toes, and small heel.
Most of the patients who have clubfoot are less mobile because their foot are smaller than the normal size. The calf muscles will continue to be smaller, which may cause the patient to complain of sore legs or fatigue earlier than peers. They also may face difficulty to stand at longer time because of the painful calluses, and lastly, limitation of dorsal flexion of the ankle joint that result in difficulty to perform leisure activity, walking, and driving.
That's all from us, thank you.